Hello, everyone. We are pleased to have you join us for Cardinal Health Lab Exchange. Welcome to today's live broadcast, Managing Laboratory Utilization. I am Bob Woodard of LabRoots, and I'll be your moderator for today's webinar. We are delighted to bring you this educational seminar presented by LabRoots and sponsored by the American Society for Clinical Laboratory Science. The mission of the ASCLS is to make a positive impact in healthcare through leadership that will ensure excellence in the practice of laboratory medicine. For more information, please visit ascls.org. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem to the green Q&A button on the lower left. Following this presentation, head over to the Community of Learning in the Lab Exchange lobby to have the opportunity to engage in live chat and have more of your questions answered on the spot about managing laboratory utilization. I would now like to introduce today's speaker, Rick Tanning. Rick is the Senior Administrative Director of Laboratory Services at HealthPartners and Park Nicollet in Minneapolis, Minnesota. He has been involved in a variety of laboratory management positions for over 30 years. Rick has been a member of the Clinical Lab Management Association since 1984 and served as state president in 1990. Throughout his career, he has also actively served ASCLS in a variety of positions, most recently as the chair of the Advanced Management Institute Planning Committee. Rick has also concentrated on process improvement, Lean and Six Sigma, laboratory standardization and integration, professional advocacy, and utilization management. Please join me in welcoming Rick to today's event. I will now turn the presentation over to him.
Thank you very much, Bob. For today's session, we're going to be talking about managing laboratory utilization, and just as a heads up, we're going to concentrate on utilization of laboratory testing. And I say that just because we could also be talking about utilization of blood products or blood management. That'll not be one of the topics of today, but some of the concepts will be similar. So to get us started, some of the objectives for today are to talk about appropriate utilization of lab testing and the development of a lab test formulary, how to use information technology to enable appropriate utilization of lab testing, and then some strategies that we will discuss, various strategies that can help address lab test utilization. Just also to give you a little bit of background, some of this comes from work that I'm currently doing in my current organization. Some of it has come from my previous organization, which was at Fairview Health Services here in Minneapolis, Minnesota. And then some of it has also been from my doctoral studies. So as we move ahead, the topics I'm going to summarize today have to do with how do you establish a utilization management committee, talk about duplicate testing and its role in utilization management, the development of a test formulary, utilization of testing algorithms, how to use data. Data is very key in this whole process, and how to use data, how to use tools in the electronic medical record, and then a project that I'm currently working on, which is genetic testing utilization in our organization. The next slide is just a cartoon, and basically the doctor's telling the patient, all your labs are back. They show a serious overuse of unnecessary and inappropriate tests and procedures. And obviously that's the issue that we're trying to address here. And there actually should be a third word introduced into that cartoon, but we need to talk about unnecessary or overutilization. We need to talk about appropriateness, and we also need to talk about underutilization, because sometimes doing more lab tests would be the better thing to do in terms of cost containment and better diagnosis and treatment. So just a little bit of background. Why is this topic so important? We need to do this because it's an important patient safety strategy in our healthcare systems. Doing unnecessary testing is not the right thing to do for patients and does not add to a more safe patient environment. We need to perform the right testing on the right patient at the right time. I'm sure you've heard that phrase many, many times, but it is really key to anything that we talk about when we talk about laboratory test utilization. And by doing the appropriate laboratory testing at the appropriate time, we can avoid doing more expensive tests and more expensive procedures and exams, because lab testing, as all of us in the industry know, is one of the most highly valued resources in healthcare. For relatively low cost, you can get a big bang for your buck. Lab testing, even though we have very high volumes of lab testing in this country with over 5 billion lab tests performed every year, and it's the single highest volume activity in the healthcare environment. There was a study done by Beth Israel back in 2013, which looked at a very high volume of results from 46 of medicine's 50 most commonly ordered lab tests. And what they found is that about 30% of all tests were probably unnecessary. Even more surprising, the results suggested that equally as many tests should have been ordered that weren't ordered. But basically, there's a 30% overall rate of test overuse in this country and a similar rate of underuse. Now, this slide I know is a little bit blurry as you look at it, but you don't need to be able to read much on here other than looking at the one red line, which kind of separates itself from all that tangled web of other lines on the graph. And this is looking over a period from the early 1980s until the current time, and the red line is the United States, and all that other tangled mess is everybody else. And basically, that health care spending in this country as a percentage of our total economy, or as a percentage of the gross domestic product, has risen steadily and pretty dramatically over these years, and is now at about 18% of our economy, much higher and growing at a much faster rate than the rest of the industrialized world. So we do have a problem, and I don't have a graph of this, but we could also show you a companion graph, which doesn't necessarily show, just because we're spending more, that we have higher quality than these other countries. And then the other issue, which comes more pertinent in today's environment, is that we are shifting from a paradigm of talking about volume and paying for volume and paying for how many we did of something, to paying for the value that we derive, or paying for the outcomes. So we're making that shift from cost to quality, from volume to value, and it all links in with the triple aim of improving patient experience, improving population health, and decreasing the cost of health care. So there have been many, many approaches that have been tried for this strategy of addressing utilization. Some of them have been pure educational in nature. The challenge is you can't get to everybody. Communications are not always read. In general, there tends to be poor compliance with the communications that are used. Re-education. How frequently do you need to provide this information? How do you deal with the fact of that influx of residents and fellows that changes every year? Just intercepting those orders as inappropriate once you accession them, it requires a very time-consuming process of communicating with physicians, interacting with physicians, and you're doing it after the fact. You're not doing it real time. You're responding to something. You're reacting to something. Requires a lot of professionalism on the part of laboratory professionals. Requires some very high-level communication skills. And unfortunately, the specimen by then has already been drawn, and you're doing a lot of backtracking. What are some of the issues in our environment, or that everything that's going on around us, that impact utilization and impact the practice of laboratory medicine? So we've had probably a very high level of implementation of computerized physician order entry, CPOE. There's a lot of clinical decision support tools that are available to us, especially in our electronic medical records and our laboratory systems. There therefore is an opportunity for us to interact with the decision maker at the time of the order and help direct decisions in the right direction. But you have to balance that with the fact that even though we have all these tools, overuse of the tools can become quite a dissatisfier for our users, i.e. our physicians and other providers. You've all heard of pop-up fatigue probably in the electronic medical record, and if you overuse these pop-ups, they tend to just get ignored. They're a dissatisfier, and they actually tick people off. The whole concept of meaningful use has entered into this, and then, as I've already mentioned, the whole paradigm shift from volume to value. This is another way to look at why do we have all these utilization issues, and it's multifactorial. We have providers, we have the clinical labs themselves, we have the patients, we have the health systems, and in each of these areas, there are a number of factors. So I'm just going to mention one here as an example. Let's talk about the providers. Let's talk about the physicians, the people ordering the test. You have to realize the reality of their practice these days. It's very complicated, and there's a lot on their plates, and they have to keep a lot in mind when they're treating their patients. There's truly a knowledge gap. Laboratory testing is changing significantly, and we're in an especially high level rate of change time in laboratory medicine when there's many, many new tests and a lot of genetic tests. And for a provider to keep up with all of that is almost impossible. And of course, they're hit from various directions with a variety of marketing about all these new tests and why they should use XYZ test versus ABC test. There's the fear of litigation, so therefore that can tend to lead to over-ordering. And then sometimes there are financial incentives to do so. In each of these areas, there are multiple factors that are all leading to inappropriate utilization of laboratory resources. This talks about one of those factors related to the providers, and this shows us in the United States, if you survey all the medical schools, and they had about a 46% response rate in this survey, it shows you how much time was spent on training and education in laboratory medicine for residents and medical students. And as you can see, it varies from less than 20 hours in some medical schools to a maximum of 61 to 80 hours, but that's in a very low number of medical schools. Most of them are in that 21 to 40 hours, and then secondarily maybe in the 40 to 60 hours. So very little time is spent on this topic. And again, in an era when this is changing so rapidly and dynamically, it's really challenging for physicians to keep up with it. Now, I shamelessly have borrowed this diagram from ARUP Laboratories in Salt Lake City. This is kind of a roadmap for what are the various components of utilization management. And it starts obviously with a concept at the left to very effective utilization management at the right. But the various components are analytics, governance. When we talk about governance, it has to do with the committee structure and how do we manage this. The analytics has to do with the data. But then the policies that you have, the formulary that you develop, how you implement it, how you maintain it. So we're going to kind of follow this as we go through some of the strategies that we're going to talk about. So data analysis, or the analytics. And here, I put in this quote, you've got to know what you're running away from and also what you're running toward. What are you trying to achieve? What are you trying to fix? Running away is not necessarily a strategy. You need to know where you're trying to go and what you're trying to achieve. Why do you need data? Why can't we just do it? Often one of the reasons you need to do that is you need to make the case. You're either making the case to the physicians and the providers, you're making the case for supportive utilization management to your administration or to your finance officers. You need data to make the case and to help you visualize where you're starting and where you have the opportunity to go to. Our stakeholders need to understand that inappropriate utilization is problematic, both overutilization and underutilization. We need to raise awareness, and we need to define the issue. Again, more about why we need data. We need to understand where we're going. We need to understand what true north is. What is the direction, and what is the ultimate outcome that we're trying to achieve? Again, we're trying to convince people in the C-suite. We need to measure the value of what we do, both in terms of clinical, cost to the patient, cost to the laboratory, cost to the healthcare system, the impact on what we do, and then we need to also be able to publicize that value. First and foremost, what is the value clinically, but also there will be a related financial value also. But data alone does not achieve what we need to achieve. You need action, you need change, and that's what will result in performance improvement. So here are just some examples, and these come from a variety of sources, but data can come from databases and tools that organizations such as the University Health Consortium might have. Or many of you do benchmarking in a product called Action.io, and so therefore you have an operational database. Or you may belong to the Premier organization, and they have tools. Or there are basic benchmarking tools out there from organizations like CHI, or your reference labs, for example, from ARUP. But then you need to layer on top of that everything related to change. How do you propose the change? How do you network and talk about the change? How do you help people adopt to new best practices? And how do you just manage the change process in and of itself? Because that is difficult. People don't like to do that. Inertia kind of wants to prevent them from doing that. So again, we need to understand the impact of overutilization and underutilization and inappropriateness. Again, both financially and from a quality point of view. We need to measure our progress. If we start to make changes, we need to know where we started and then monitor the improvement or sometimes, unfortunately, the lack of improvement. And then we also want to be able to compare ourselves and to benchmark with similar organizations to really look at, are we able to achieve best practice or improved practice? And many organizations, when they do this, set a goal. Maybe in the benchmarking, you're trying to be top quartile. The last organization I worked in and in the one I'm in now, our goal is usually to be top decile, to be top 10%. But you need to kind of know where you're starting and ultimately what you're trying to achieve. Unfortunately, and I don't have this on the slide, some organizations use this inappropriately and actually take the benchmarking numbers and apply it to you before you're able to make change, and it becomes your target or your budget, which is very inappropriate and almost impossible to achieve. So sources of test utilization, and I'll use my current organization, HealthPartners and Park Nicollet. The reason there's two names there is we are a merger of two organizations that came together about 2 years ago. This is the third year of that combination or that relationship. And this year, I'm relatively new in my job. I'm just in the fourth month of my position. The lab integration part of that is now underway. So we have various sources. We have our lab information systems. Unfortunately, we have two of them at this moment. SunQuest on one side of the organization and SOFT on the other side. We have an electronic medical record. Fortunately there, we're both using the same product, but currently different versions, and are currently in an integration project to bring those together a year from now. We use decision support systems, and we use the advisory board quite a bit in a product that they use called Crimson. Again, because we're coming together, we have two different primary reference labs, which will change over time. But currently we'll be using both ARUP in one organization and Quest in the other. And then we use a variety of tools and have a variety of tools available to us. University Health Consortium, because one of our hospitals is a member of that. We have Premier, because one of our sides of the organization is a Premier member. The other side is an Ovation member. We have access to the tools that CHI Solutions has available. And then we are using the resources of ARUP to help us with both our reference lab, but also to look at things like outreach and utilization. So each in your own organization, you have hopefully a variety of resources that are available to you and a variety of sources of data that are available to you. Just to give you an example of some benchmarking. So this is an example from my previous job where initially the target that we were trying to set for ourselves was to be at the 25th percentile, the top quartile. Ultimately that was revised to try to be in the top decile. And what you see here is my lab, or the place that I was. We were starting at the 50th percentile. So we weren't by any means the worst. We were average. We were kind of in the middle. And then if you compare to specific organizations, and I've made them generic for the use of this, we were comparing anything from people in the 30s, so in the lower part of that, to people at the 90th percentile. Well, I have that backwards the way this one works. 90th would be actually on the low end. 38% would be on the better end. And then if you look at pure numbers, our lab, so I'll pick one of the labs that was at Fairview, we were actually at the 67th percentile. Again, the higher that percentile in this product, the lower your performance is. So you want to be in a lower number versus the higher number. But we weren't that far from the 25th percentile. But when we adjusted that to the 10th percentile, we had much more of a change to make. One of the tools we use is to monitor our sendout testing, look at the shifts of volume, look at the shifts in test mix. And we try to do that on a regular basis. Compare last year to this year. What has changed? What has increased dramatically? What has decreased dramatically? Has the total volume increased? Has the expense changed dramatically? So maybe our volume stayed the same, but the mix of expensive tests changed. So really trying to take a deep dive look at your sendout testing and see what opportunities you have to try to address some of those utilization issues. And many of our really good reference labs do a nice job of trying to bring those things to our attention. Even though it might drive work away from them, they're trying to provide us a service and help us address test utilization. Another way to look at this is we can hopefully start to look at what tests should we be doing in-house ourselves versus continuing to send out to a reference lab. I have this last slide and this slide slightly out of order because this again goes back to look at benchmarking. And again, what you see is this is measuring billed tests in a variety of ways. So billed tests per acute discharge, billed tests per acute patient day, acute test or lab test versus discharge, adjusted discharge for complexity, or adjusted patient day based on complexity. And again, looking at where you are, we are lab X. What is our percentile rank? Again, a lower number is better. What is the 25th percentile? So we kind of see 25th and where we might have the opportunity to move to. So for example, if I look at the second line, inpatient billed tests per patient day, we are at the 40th percentile, but the 25th percentile is at 7. We're way off on a patient day perspective. And so again, how you look at your data, how you pick your targets is very, very important. So just using inpatient test utilization, because that's what that last slide was about. And when I was at my previous position, that is where we started, to look at inpatient utilization. And for us at the University of Minnesota, inpatient utilization was about half of all the testing done in the laboratories on that campus. So you need to kind of start with that broad, high-level look at your utilization. And one strategy, again, there's many, many strategies here, but is to look at it on a DRG basis. Which DRGs, and we did it in other jobs, I've done similar things with blood management, which DRGs are the biggest consumers of your product, whether it be lab testing, whether it be blood products, and really trying to kind of narrow down your focus so you're not trying to boil the ocean, so to speak. So look at all lab testing by DRG, and then you can dig deeper into that. Maybe you've identified your top 20 DRGs. Then start to look at it by service, by physician. You can dig even deeper and look at it by specific tests. And you can dig even deeper depending on your data sources by what are the outcomes, what is the length of stay, what is the cost. Again, you need to start at the top at a high-level look and then keep digging deeper to help you define your strategies. This is a very hard slide to read, but it's looking at that saying, what are the top MSDRGs in my system? And in this case, 20 DRG categories accounted for 43% of all test utilization in this institution. So this is a way to start, because you can address a significant amount of your utilization by focusing in on these DRG categories. And then you can start to look and do some comparison. Again, this depends on your data sources. This happens to be from the UHC, University Health Consortium. But in various areas, I could look at how I compared. In the upper left-hand corner, for example, heart transplant, lower left-hand corner, liver transplant, and then various categories of DRGs, and where was I looking at tests per case versus where was somebody else. Again, you have that opportunity to compare to a group. You can compare to specific people in the group, but trying to get that high-level look at where do we compare with the people we want to be compared to. So moving on a bit, one of the key aspects to utilization management is to really have a structure, an ongoing project or process around utilization management. And a key piece of that becomes a utilization management committee with goals to look at optimizing your utilization for your patients, reducing unnecessary testing and therefore reducing costs, trying to get best practice. And so again, depending on where you are and what sources of data and what benchmarking you have, set some best practice targets for yourself. Improve appropriateness by using evidence-based best practice protocols. Provide consultative guidance to the physicians and the residents to help them order the right tests. We'll talk about some aspects of this as we go through this. When you form the Utilization Management Committee, you want to make sure you have the right people at the table. A bias of mine, and if you look in the literature, this tends to be true, it's not always successful if it's a top-down, administration downward type of thing, or even if it's a lab to physician type of thing. It needs to be collaborative, and it's usually more successful if the physicians or the providers themselves are helping to lead that process, and then the lab can facilitate that process. Make sure you have high-level leadership support. Your CEO, your Chief Operating Officer, your Chief Financial Officer, whatever it be, it's important for this to be an important priority of your organization. Make sure your process is open and transparent and that it's multidisciplinary. It's key, I can't emphasize it enough, that information technology is key to the success of this. There's an opportunity to use tools that help your process, so you need active support, participation, and partnership. Focus on patient care and best practice. Cost reduction will happen, but don't make that be the focus of why you're starting and where you're going. That'll happen if you do this properly. And then you have to remember to monitor and report, and that helps build your credibility. It helps build support for the next thing you want to tackle, and to make sure you share your successes and celebrate them. So examples. These are just examples. Again, they come from my previous position because I'm relatively new in this position. We developed alerts in our EPIC electronic medical record system to help us address duplicate testing. And I keep in touch with the people there, and I know that just recently they've implemented one of these. We developed a partnership with our reference lab. So that's one thing I'd always recommend. And look at what resources are available to you to help you, because there are people out there who've done some of this. And whether it's through networking that you talk to other people or you use organizations that you already have relationships with, it can be very helpful. And for Fairview, ARUP was going to help them develop a formulary. Add genetic counselor support to help you review all those expensive molecular and genetic test orders. So this was in the process of occurring right as I left Fairview, but as I'm now in HealthPartners and Park Nicollet, we have recently hired 2 genetic counselors that will be based in the laboratory. One of them started 2 weeks ago, and the other one starts next Monday. And I'll be talking about genetic testing at the end, but this in itself is a key component to our strategy. We work with our benchmarking or our performance data analysis program. In the case of Fairview, that at the university, that was University Health Consortium. We worked with the residency program, and actually they reached out to us. They wanted to make their residents more aware of pricing and cost when they ordered tests. And if anybody ever comes and asks you that, please don't avoid that question and ignore it, because it's a great opportunity. Communication is important, and then ultimately sometimes developing physician report cards to help compare performance. So laboratory test formulary, which is one component. We're all familiar with formularies in the pharmacy world. It's basically a utilization device where you can help focus on things that you allow to be ordered easily, things that you make more difficult to order, things that you don't allow to be ordered. And it's been done for years and years in pharmacy, and now it's becoming more and more common in the laboratory. You want to make it easier for clinicians to order the right tests and hard for them to order the wrong tests. We usually do it on a criteria-based or a tier sort of structure. If a test really only needs to be ordered by a small group of specific physicians, then you restrict it to that small group of physicians and don't allow other people to order those tests. And then an example of a tiered process could be a test that anybody can order, a test that only specific specialists can order, or tests that maybe require further approval before they can be ordered by anybody. And that could be a genetic counselor approves it, a department head approves it, a pathologist approves it. Testing algorithms are another tool in the toolkit of test utilization. These are all about best practice and evidence-based testing protocols. Usually they're disease-specific. There are tons and tons of examples of these in the literature, whether they're from Mayo or ARUP or academic health centers. People all over the country have implemented these types of protocols, and you don't need to create them from scratch. There's different types of algorithms. Some of them are IT-driven, where there's clinical input and information, but then you are able to program it and have it be function based on the IT system. Some are laboratory-driven, pathologist-driven, genetic counselor-driven. There can be different types of algorithms that you can use. Duplicate testing. So in a variety of organizations I've worked for, duplicate testing tends to be a significant issue that contributes to overuse of testing and inappropriate use and a waste of money. Sometimes it's due to the misuse of your electronic medical record and the misuse of physician order entry. There's functionality that exists in those systems, but physicians don't always use them. I'm finding just in the organization I'm in with now, it's more in a problem in one half of our organization, but they found a way in the other half of the organization to make those tools more, they force them a little bit more so that they're used properly. When you have multiple physicians on the same case, that can often result in duplicate testing. Overuse and abuse of standing orders, and the fact that standing orders can stay open forever can sometimes lead to overuse of lab testing. Defensive medicine. We don't want to be sued. We want to make sure we cover all our bases, so we order everything. When you have residents in an academic setting, that can often result in over-ordering. Or just the fact that your test catalogs and the names of your tests and the descriptions are confusing can lead to a fair amount of misutilization or inappropriate. Some strategies for this: you can build rules in your electronic medical record. We use the phrases soft stop and hard stop. A soft stop is just when something pops up and tells you something and hopes you do the right thing. A hard stop makes you do the right thing. It doesn't allow you to proceed if you've done something that you're not supposed to. Education is part of it, but it can't be the only piece. Limiting the time frames on your standing orders, cleaning up your test catalog, and then reviewing the physician and specialist favorite lists in your electronic medical record. We find that, you know, your Epic system or whatever your electronic medical record gets set up, and then you're up and live on it for years and years, and you never go back and take a fresh look at those frequent ordered lists or those favorite lists. And a lot of times the misuse is coming because those have not been adjusted. This talks about that soft stop versus hard stop. If you want a good resource, there's a lot in the literature from the Cleveland Clinic has done a lot of work in this regard. And they did a lot of studies and found that there was not a lot of value when you just did a soft stop because it didn't force you to do anything. And if anything, it just annoyed doctors because all these things popped up. So you got this pop-up fatigue, and they just ignore it, they don't read it, they bypass it. They did this, they tried it, it ultimately showed them that they needed something firmer. And like I said, in my previous organization, a soft stop technology has recently been put in place for some duplicate testing, and I'll be interested to watch them and see if it's successful or not. This is very hard to read, and I guess it's harder to read than I thought it was going to be. But this is a slide, and it's an example of what Cleveland Clinic did because they ultimately did a hard stop. And the success of their hard stop was they looked at testing, and they started with testing, and they started with a short list of tests that should never be ordered more than once in a day or once in 24 hours on an inpatient. Ultimately, that got expanded to more than once in a stay and maybe more than once in your life because there are certain tests like genetic tests that don't need to be ordered more than once in your life. But when one of those tests is ordered, this pops up and it basically tells you this has already been ordered. So if we're talking about once in 24 hours, you tried to order the test, hemoglobin A1C in this case, you find out it was already ordered in the previous 24 hours. But not only do we just tell you that, we give you the result and we tell you who ordered it and we tell you when. So, and usually then that just stops the whole process. But this is a hard stop. They literally can't continue without making a phone call to somebody, and maybe there's some special cause or special reason, but this just stops them. They can't proceed in this case. Now, we wanted to do this at Fairview, but we just got pushback from our IT department. Even though the physicians supported it, we couldn't get the IT department to do it. Now, Cleveland Clinic, which is also on Epic, they just did their own custom programming. But at Fairview, they were not willing to do custom programming for us. Hard stop, you can do various scenarios. I've already talked about this. Once in 24 hours, once in an inpatient stay, once in a lifetime. This was an example of the initial short list that Cleveland Clinic did. Dr. Gary Prokop is the person who has been very, very involved with this at the Cleveland Clinic and has written about it and talked about it. So this was a short list of tests that they decided to try as their pilot. Ultimately, they continued with all these tests and ultimately expanded beyond this list, but they ended up taking uric acid off because they found there were certain patients, especially patients with certain chemotherapy, where it was appropriate to do it more than once in 24 hours. Duplicate testing alerts, that's kind of what we just talked about. Other places have done this. Example here, University of Mississippi Medical Center. It monitors things like CBCs and basic metabolic panels. It looks at tests that are ordered duplicate within a 4-hour period. Again, they did a strategy, they put something in place, and they saved, just on this strategy, about $146,000. Genetic testing. So I told you I'd talk about genetic testing specifically. It's a major effort that I'm deeply involved with now in my new organization. And one of the things you need to understand about the organization I'm in now, it's not only a provider of health care, and we have hospitals and clinics, but we are also a payer. HealthPartners is one of the major payers in the state of Minnesota. So we're able to look at this both from what will we pay for, what will we approve, and then also from the clinical side about what we will do. So genetic testing. This is increasing pretty dramatically year over year, 20 to 25%. It now accounts for about 15% of all laboratory costs and is anticipated to reach about a quarter of all lab costs. Again, it talks about the increase, it talks about the cost, and I kind of duplicated myself there by saying the same thing twice. So sorry about that. Current situation in our organization. Based on the year 2013, we were spending about $6.4 million in the HealthPartners side and about $1 million at Park Nicollet and some of the other components of our organization. The risk projection that was done showed that there's going to be about a 15% annual volume increase, and that the misuse or overuse of these tests is about at a level of 30%. And you'll see that 30% being pretty common if you look at various things in the literature. What reference labs tell you, there's an organization out in Seattle called Plugs that looks at lab test utilization, and 30% is the pretty common number. And then that 30% is a combination of things that just shouldn't be ordered at all, or things that were just inappropriately ordered and need to be changed. This affects all aspects of care. It's predictive, it's diagnostic, it's therapeutic. You get into germline, pharmacogenomics, genetics, and tumor markers. The scope of genetic testing, there's a variety of aspects to this. There's a rapid pace of new tests coming on the market. It's very complex. It's very difficult to keep up with it all. There's a growing number of multi-gene testing panels that are available on the market. Often there's limited evidence of clinical utility for these things. There, more and more, interestingly enough, is limited access to genetic counselors. We're seeing that in parts of the Minneapolis-St. Paul area, where access to genetic counselors isn't nearly what it should be. And then you have unique coding that goes with all of this, which makes the billing of it very complex. But it all leads to the cost and the experience that we have with genetic testing. Obviously, this is all related to the triple aim of evidence-based quality care, exceptional experience for our patients, and affordability for our patients. And I've listed some other points here. Affordability over in the lower right-hand corner. We talk a lot in our organization about the total cost of care and really pay a lot of attention to that. But you can read these bullet points yourself, but all of this does relate to the triple aim. And the model that we're putting together, if you start at the top, this is all about knowledge management. How do we manage this ever-changing, daily change in what the environment is in this, what the landscape is in this? Because the testing keeps changing. There's new tests all the time. So part of our structure is we're going to be looking for a software product to support us, where there's companies out there that try to keep up with all of this so that we don't have to try to keep up with all of it ourselves. We have a data source that we can go to. Expert panels. So when we're considering whether we should allow performance and payment for different tests, we'll put expert panels of physicians from a specific specialty together, and we've decided, both physicians from our organization and because we're a payer and we pay multiple organizations, we need to have experts and physicians from other organizations also. And then developing a genetic testing database. And then we kind of split off into two things. What do we do on the care side, the provider side, and what do we do on the plan side or the payer side of this? So on the care side, it's things like informed consent. How do we use Epic as decision support? How do we use Epic as ordering and process support? How do we code and bill? Where do we send these things to? What are the labs we're going to use? On the plan side or the payer side, how do we provide information to our members? How do we develop coverage policies? How do we deal with prior notification and pre-authorization? How do we edit claims? And what are our contracting and payment strategies? So this is the model that we are in the beginning stages of in our organization. Some of our current strategies are we've developed a genetic testing committee structure. There's an operations committee, a steering committee, and kind of a day-to-day lead committee. I happen to be on the lead committee, which kind of is driving some of this. We have hired 2 genetic counselors. I've already talked to you about that. They work very closely with our sendout coordinators at each site. They review all genetic test orders. They determine the appropriateness and approve, modify, or delete orders, communicate with physicians, review the medical record. They're really concentrating on lab test orders. And right now their process is somewhat complicated due to IT issues, but over time we will address those. They help us assure that informed consent has happened, and they investigate the appropriate place to send this testing to. We're forming expert panels. I already talked about that. We have started to develop 2 formulary committees, a payer formulary committee, and then on the care side, a provider formulary committee. We have entered into a membership with the PLUGS program, the utilization program that started with Dr. Mike Astian at Seattle Children's Hospital, and they do more than just pediatrics. They're a great resource for us. And then right now we're in the process of evaluating these different software systems, and we have an RFP that'll be going out so that we can select the appropriate tool for us to use. Back to the genetic counselors. Our first genetic counselor for the lab, these are people, they don't do counseling with patients per se, because we have other genetic counselors that do that. These are lab-based, and they're really reviewing the orders and help us do the appropriate orders. We already have saved thousands of dollars in just the last 2 weeks with our first genetic counselor who has just caught things that are just stupid in some cases and inappropriate. And we've canceled things and we've changed things. She's had very good conversations with physicians, and already in 2 weeks now physicians are starting to call her. So it's been a good change for us. What are the keys to success in genetic testing? Needs to be multidisciplinary. It needs to be an open, transparent, collaborative process, focused on patient care, evidence-based, reporting of results, leadership sponsorship. This is not unique to genetic. This is for everything related to utilization management. So I actually got done a bit faster than I thought I would. So we now have time, before we go to kind of the question, the community, we have time for people to submit questions that I can answer during the remaining time.
Yeah, well, thank you, Rick, for that informative presentation. I'm thrilled to be a part of Cardinal Health Lab Exchange. Before we get started on the question and answer session, I'd like to remind our audience they can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. And we'll try to answer as many questions as we can. We do have a question here now. I think this is regarding the duplicate test alerts. Gene Scott at Sonora Regional Medical Center asks, is the $146,000 saved the cost of the test or the charge for the test?
That's a very good question, and it actually is, and the best way to measure this is actually the cost that was saved. The charges would be obviously much, much more, and I really don't mean a whole lot, but this is actually the cost of what that testing would have been. And I believe in the case of the example I gave you, it was the direct cost. So it didn't have indirect costs in it, but it was the direct cost of doing the testing.
Oh, well, thank you, Rick. We'll wait a second to see if any more questions come in. In the meantime, I would like to thank our sponsor, ASCLS, for making today's educational webcast possible. And after we're done here, we'll encourage everyone to go to the community of learning following this presentation to have the opportunity to engage in a chat with Rick Panning and your peers, as well as get answers to any burning questions you may have in regard to managing laboratory utilization. So there is another question that's come in. This is from Terry Alar at Reynolds Memorial Hospital. How did you get the physicians to buy into the algorithms for ordering laboratory testing?
So, that is a challenge, and that, again, is a very good question. And that's why often in these, as we set up our governance structure and we set up our committee structure, you need to involve physicians from the beginning. Similar thing holds true for blood management when you're trying to make changes in the way they use blood products. And you need to involve them. So if your algorithm has to do with a specific specialty, or if it's across specialties, you make sure you include physicians as you either develop that algorithm or as you review an algorithm that you have found from another organization. You need to involve them in the process and try to get those people who are thought leaders as physicians within your organization so that they can then pass it on to their peers and really show that there's buy-in and to support that. So it has to all do with the collaboration and the communication and the involvement from the beginning. You just have to kind of build that trust.
Okay, our next question, and I hope I pronounced this correctly, is from Jean Zimmer at the Coteau de Prairie Healthcare. How many evidence-based order sets do you have in place?
Okay, so I'm not going to be able to give you a number in my current organization because I'm relatively new. That number is relatively small at this point, and we're currently working with our formulary committee, which is primarily composed of physicians with a variety of specialties, and our expert panels to help us develop more of them. Right now we're in a situation in our organization that the process to do that and get them implemented into Epic is going to be relatively small for the next year, slow for the next year, because we're in that integration process of trying to integrate our two Epic systems. But it'll be part of the enhancement or optimization afterwards with the intent of building more of these. But there are a few of them built now. Some of them are the common ones like thyroid, celiac disease, those types of things, which have been built and were built early on. So we're somewhat in the infancy of that process.
Well, thanks again, Rick, and again, thanks to everyone for the questions. And I would again like to encourage everyone to go to the community of learning, to talk further with Rick about managing laboratory utilization. And I'd like to remind everyone that today's webcast will be available for on-demand viewing through October of this year. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you very much, and until next time, goodbye.